Welcome back to The Deep Dive, your shortcut to being well-informed. Today, we're tackling a really big one, diabetes mellitus, or DM. It's probably the most widespread and, honestly, complex chronic condition nurses deal with. It just throws the body's whole energy system off balance. We're going to dig into the core pathophysiology, the, well, scary complications, and the really precise management strategies you absolutely need to know.
That's right. And if you boil it all down, the number one concept here is glucose regulation. DM is really the prime example of what happens when that regulation fails. The body can't metabolize nutrients properly, glucose, fat, protein, and that failure just ripples through everything. It causes emergencies, sure, but also that slow chronic damage. And it really starts with this fundamental hormonal tug of war.
You mean insulin versus glucagon, both from the pancreas. We hear insulin called the key for glucose getting into cells. So how does that normally work when everything's running smoothly?
Yeah, insulin is kind of the hormone of plenty. It's released after you eat when blood glucose goes up. It helps glucose move into cells for energy right away, but just as crucial, it triggers storage, making glycogen in the liver and muscles. That's glycogenesis. So effectively, it lowers blood sugar.
And glucagon is the counterbalance.
Exactly. Glucagon's the hormone of starvation, you could say. It comes out when blood sugar gets too low, preventing hypoglycemia. It tells the liver, hey, release some stored glucose. That's breaking down glycogen, glycogenolysis, or even making new glucose from things like protein gluconeogenesis. This back and forth keeps things stable, which is vital, especially for the brain. It needs constant glucose.
Okay, so let's talk about the breakdown. DM means not enough insulin action, either none, or the cells resist it. What's the immediate chain reaction, those classic symptoms?
Well, first, it's almost like physics. Insulin isn't opening the door, so glucose can't get in. The cells are starving. That triggers polyphagia, excessive eating. The brain's screaming for energy it can't access, and at the same time, all that unused glucose piles up in the blood. That's hyperglycemia.
And that high sugar concentration then affects the kidneys, right? Like a magnet for water.
It really does. Once blood glucose gets above a certain point, the kidneys just can't reabsorb it all. It spills into the urine. And glucose is osmotically active, so it pulls huge amounts of water and electrolytes with it. That's osmotic diuresis. That leads straight to polyuria, frequent urination, which then causes dehydration and intense thirst, polydipsia. Those are the classic 3 Ps. Shows you the fluid balance failure right there.
But there's more metabolic chaos, isn't there? The acidosis part. If cells starve, the body turns to fat.
Yes, exactly. The body switches gears and starts breaking down fat like crazy. That's lipolysis. And a byproduct of that is ketone bodies. These are acidic. When they build up, you get metabolic acidosis. This is a hallmark, especially of type 1 DM, where there's usually zero insulin being made, often due to autoimmune destruction of those beta cells. The body's desperate attempt to fix this acidosis is that very distinct Kussmaul respiration, deep, fast breathing, trying to blow off CO2, which is acidic.
And that's when a nurse might notice that sort of rotting fruit smell on the breath. Acetone. So that difference is key. Type 1, absolute insulin lack. Type 2 usually starts with resistance. Maybe later the pancreas can't keep up.
Right, and understanding that cascade helps us understand the acute complications, the big 3 emergencies that need fast, different responses. You've got Diabetic Ketoacidosis, DKA, that's hyperglycemia plus acidosis plus ketones. Then you have hypoglycemia, low blood sugar.
And the third one, Hyperglycemic-Hyperosmolar State, or HHS. Now wait, HHS often has way higher blood glucose, like over 600 sometimes. Why isn't it usually as acidic as DKA? What stops the ketones?
That's a really critical distinction. It comes down to whether there's any insulin around. In HHS, there's usually still just enough insulin trickling out to prevent that massive fat breakdown, lipolysis, and therefore ketone formation. So you typically don't see the severe acidosis or the Kussmaul breathing, but that tiny bit of insulin isn't nearly enough to control the glucose. So sugar levels go sky high, leading to much more profound dehydration and incredibly high blood osmolarity. Think DKA, acid emergency. HHS, extreme dehydration emergency.
Got it. So those are the immediate fires, but then there's the long-term damage, the chronic vascular problems that just undermine everything over years.
Exactly. Chronic hyperglycemia is toxic. It damages organs by thickening membranes and small vessels, direct glucose toxicity, and leading to tissue hypoxia, lack of oxygen. We usually split this into macrovascular and microvascular damage.
Okay, macrovascular, that sounds like the big blood vessels. So heart attacks, strokes.
Precisely. Coronary heart disease, cerebrovascular disease, peripheral vascular disease. These are the major killers. And that's why management targets are so aggressive. Trying to prevent these means really tight control, generally aiming for blood pressure below 1490, and keeping LDL cholesterol, the bad kind, under 100. These are key prevention goals.
And then the microvascular problems, smaller vessels. These seem to hit quality of life hard, like diabetic retinopathy, DR.
Yeah, DR is the top cause of new blindness in working-age adults. Poor glucose control damages the tiny vessels in the retina. Over time, this causes hypoxia. The worst form is proliferative diabetic retinopathy. The body tries to grow new blood vessels, but they're fragile, they leak, they bleed easily. Best prevention: tight glucose and blood pressure control.
And the kidneys take a hit too.
Oh, definitely. Diabetic nephropathy. Diabetes is the #1 cause of end-stage kidney disease, needing dialysis or transplant. The risk really climbs after someone's had diabetes for 10-15 years, especially if their glucose and blood pressure are poorly controlled. Again, BP is crucial. Keeping it under 440/80 helps slow down that kidney damage. And then there's diabetic peripheral neuropathy, DPN.
Nerve damage, that sounds awful because it means losing sensation, right? People might not even feel injuries.
Exactly. That loss of protective sensation is incredibly dangerous. Combine it with poor blood flow from the vascular disease. It's a setup for foot ulcers that won't heal and potentially amputation. It can also cause muscle weakness, leading to foot deformities like Charcot foot, where the bones and joints actually break down and collapse, makes ulcer risk even higher. And we always have to remember infection risk. High blood sugar hampers immune function, slows down white blood cells, so infections can get serious, fast.
Okay, shifting to diagnosis, beyond those 3 Ps we talked about, what are the definitive lab tests, especially the ones that show long-term control?
Well, the gold standard for looking at average blood sugar over the past, say, 3 months or 120 days is the A1C test, glycosylated hemoglobin. A level of 6.5% or higher is diagnostic for diabetes. But when we're managing someone, we watch it closely, an A1C over 8%. That signals poor control. Definitely time to rethink the treatment plan.
And for the immediate picture, like
That'd be the fasting blood glucose, FBG. Diagnostic is 126 milli-UG DL or more, but you need to confirm it on a separate day. Or if someone has those classic symptoms, polyuria, polydipsia, maybe weight loss, and their random non-fasting glucose is 200 or higher, that also confirms it. And screening is key. We recommend testing for all adults over 45 or earlier if they're overweight and have risk factors like family history, inactivity, hypertension, things like that.
Right. So moving into management, the goals are pretty clear. A1C, ideally 7.0% or less, pre-meal glucose somewhere between 70 and 130. But we have to hammer this home. Drugs are not a replacement for diet and exercise, right? Those are foundational.
Absolutely critical. Diet and exercise first. But when we do get to pharmacology, insulin is, of course, essential for type 1 and often needed eventually for type 2. It's a high alert medication. The regimens get complex, trying to mimic the pancreas. You have basal insulin for background coverage and prandial or bolus doses for meals.
When you're teaching patients about injections, what's a crucial safety point about where to inject and the timing that often gets missed?
Okay. Absorption is quickest in the abdomen, so that's usually the preferred area, but you must rotate injection spots within that area. If you keep injecting the same exact spot, you can get lipodystrophy, affecting absorption. Timing is a huge safety issue. Rapid-acting insulin, like Lispro or Aspart, needs to be given within maybe 10 minutes of starting the meal. Regular insulin is a bit slower, so it's usually 20-30 minutes before eating. Here's the really critical part. If a patient checks their sugar before eating and it's low, they need to delay the injection until after they eat. Giving insulin when already low is asking for severe hypoglycemia. And one more absolute rule: never mix long-acting insulins like Glargine or Detamir with any other insulin in the same syringe.
Vital safety points. Okay, what about the non-insulin drugs? Many have significant safety alerts nurses need to educate patients about. Let's start with metformin.
Metformin, a big one-eyed, mostly works by reducing how much glucose the liver makes. The major safety alert is about lactic acidosis. It has to be withheld before, and for about 48 hours after, any procedure involving 5E contrast dye or major surgery. Why? Because if kidney function takes a hit, metformin can build up and cause this potentially fatal acidosis. You have to confirm kidney function is back to normal before restarting it.
And the glitazones, TZDs. They increase glucose use by cells, but they carry a serious warning.
A huge one, a black box warning. They should not be used in anyone with symptomatic heart failure. They cause fluid retention and have been linked to increased heart-related deaths. Then you have the SGLT2 inhibitors, the drugs, ending biflosin. They work by making the kidneys pee out extra glucose.
But that mechanism has led to concerns too, hasn't it? Like acute kidney injury, and I think specifically canagliflozin was linked to a higher risk of lower limb amputations.
That's correct. Those are significant risks to monitor. And finally, the incretin mimetics and DPP-4 inhibitors, they work differently, more with gut hormones. The key warning there is an increased risk for pancreatitis. Patients need to know to report any sudden severe abdominal pain immediately.
Okay, switching gears to lifestyle safety, nutrition and exercise. What's the really important instruction about alcohol for patients who use insulin or drugs that stimulate insulin release?
Alcohol basically stops the liver from making new glucose, gluconeogenesis. This means it dramatically increases the risk for delayed hypoglycemia, maybe hours later. So the rule is, if you use insulin or those specific meds, only drink alcohol with or shortly after eating a meal containing carbohydrates, never on an empty stomach.
And exercise. It's great for management, improves insulin sensitivity, but it can be dangerous for type 1 patients if they're not careful.
Extremely dangerous if done wrong. This is a non-negotiable safety rule for type 1. Vigorous exercise should only happen when blood glucose is between 100 and 250 milligdl A and B. This is crucial. There are no ketones in the urine. Why? Because ketones mean there isn't enough insulin available. Exercising in that state will actually make blood sugar go higher, pushing them towards DKA.
Wow, okay. So finally, preventing injuries from neuropathy and poor circulation. That foot care piece is huge for preventing amputations. What are the absolute must-dos?
Daily foot checks are mandatory. Use a mirror if needed or have someone else look. Pay special attention between the toes. Footwear is critical. Shoes need to fit well, be protective, low-heeled, and have enough room, usually about half to 1 inch longer than the longest toe. And because of that potential loss of sensation, patients must never go barefoot inside or out, and never use heating pads, hot water bottles, or electric blankets on their feet. They could cause severe burns without even feeling it.
Okay, let's wrap up with handling low blood sugar itself. Hypoglycemia. It shows up in stages, right? Patients need to recognize the signs.
Yes. Early signs are usually neurogenic, the body's adrenaline response. Sweating, shaking, feeling anxious, sudden intense hunger. If it progresses, you get neuroglycopenic symptoms because the brain isn't getting enough glucose. Confusion, slurred speech, drowsiness, eventually seizures or coma. And we need to warn patients, especially those with long-standing type 1, about hypoglycemic unawareness. Their body stops giving those early warning signs, making severe lows much more dangerous.
And if someone does feel those mild symptoms and they can't act, the standard advice is the 15-15 rule.
That's the common home treatment guideline. If blood glucose is under 70 milligdl and they're conscious and able to swallow, treat with 15 grams of fast-acting carbohydrate. That's like half a cup, 4 ounces of juice or regular soda, or maybe 3 to 4 glucose tablets or 4 sugar cubes. Then wait 15 minutes, recheck blood glucose. If it's still low, repeat the 15 grams of carbs. If someone is unconscious or unable to swallow, that's an emergency. Needs prescribed glucagon injection, IM, or sub-Q, or, in a hospital setting, IV dextrose.
This whole deep dive really underscores just how much is involved in managing DM. It's this constant high-stakes balancing act affecting every system. And so much of it depends on the patient's own self-management, which hinges on the education and safety knowledge provided by the nurse.
Absolutely. The core challenge is keeping blood sugar as close to normal as possible, euglycemia, without causing dangerous lows, and preventing those long-term complications. It means teaching those survival skills, how to inject insulin, check blood sugar, what to do on sick days, right from the beginning. It's constant vigilance every single day.
So the final thought maybe to leave you, the listener, with is this. Managing diabetes demands huge lifestyle changes. Think about the sheer complexity for a patient. Turning all these medical rules, the timing, the drug alerts, the foot checks, into a daily routine requires enormous commitment, psychologically and physically. Keep that complexity in mind when you're working with patients and planning their care.
Well said. It truly is a partnership.
That's all for this deep dive. Thanks for joining us, and we'll see you next time.